Well, welcome everyone. We'll go ahead and get started. My name is Mina Nabavi, and I'm a program director with the University of Alabama at Birmingham School of Public Health's Office of Public Health Practice. I'm excited to welcome you to today's webinar, The Role of Screening Tests for Early Identification of Patients at Risk for Multidrug-Resistant Organisms in Healthcare Settings, featuring Dr. Rachel Lee, Associate Professor in the Division of Infectious Diseases at UAB and Chief Healthcare Epidemiologist for the UAB Health System. This is the fifth webinar that is part of our webinar series focused on multidrug-resistant organisms, or MDROs. This webinar is made possible by the Alabama Regional Center for Infection Prevention and Control Training and Technical Assistance, or ARC-IPC. The ARC-IPC was established to meet the consultation and support service needs surrounding infection prevention and control throughout the state of Alabama. The center is a collaborative effort of the Alabama Department of Public Health's Infectious Disease and Outbreaks Division and the University of Alabama at Birmingham. The ARC-IPC provides training and technical assistance to infection prevention and control and public health professionals in areas needed to detect, respond to, control, and prevent infectious disease outbreaks. You can learn more about the center, view and listen to past trainings, webinars, and podcasts, request training and technical assistance, and view infection prevention and control resources at uab.edu/ARC-IPC. You can also email arcipc@uab.edu with any questions and stay up to date about future trainings by signing up for our newsletter on the homepage of our website. We would like to thank our co-sponsors for today's webinar, the Deep South Center for Occupational Health and Safety and the Alabama Statewide Area Health Education Centers. You can learn more about their programs and the centers as a whole at the websites listed on this screen. We'd also like to let you know about our next upcoming webinar with Ms. Amy Ward and Dr. Spencer Durham, an MDRO webinar series double feature, where we will delve into two topics during this webinar. Ms. Amy Ward, Patient Safety Manager with Alliant Health Solutions, will present on communicating critical infection prevention information among key stakeholders to improve resident outcomes. And Dr. Spencer Durham, Associate Clinical Professor of Pharmacy Practice at Auburn University, will present on the decline of antimicrobials and the significance of antimicrobial stewardship. This webinar is presented by the Alabama Regional Center for Infection Prevention and Control and is co-sponsored by the Deep South Center for Occupational Health and Safety and the Alabama Statewide Area Health Education Centers. It will be held on July 10th at 1 p.m. Central Standard Time, and it will be a little bit longer than our typical seminar since we have two speakers. This session marks the culmination of the ARC-IPC's MDRO webinar series, serving as its sixth and final installment. Continuing education credits have been approved for nurses by the Deep South Center for Occupational Health and Safety for this program. In order to receive credit for this training, you must 1, register for the training, 2, watch the entire program, and 3, complete the evaluation following the program. Upon completion of the evaluation, you will be redirected to the Alabama Nursing CEU request form, which you also need to complete. CEUs will be awarded by the Deep South Center for Occupational Health and Safety. You do not have to submit directly to the Alabama Board of Nursing. CE units for this program will expire on June 20th, 2025. If you experience any issues, please email arcipc@uab.edu. We will place this email in the chat box as well. And finally, it's my pleasure to introduce our speaker. Dr. Rachel Lee serves as an associate professor in the Division of Infectious Diseases and holds the position of Chief Healthcare Epidemiologist for the UAB Health System. She earned her medical degree from the UAB School of Medicine, completed residency training in internal medicine at UAB, and pursued fellowship training in infectious disease quality and patient safety, also at UAB. As UAB's chief healthcare epidemiologist, she employs evidence-based medicine to mitigate healthcare-associated infections. Her research primarily investigates multi-drug-resistant pathogens and their implications for infection control. Dr. Lee is recognized for her expertise in infectious diseases, encompassing areas such as influenza transmission and infection prevention and control strategies. Without further ado, it's my pleasure to turn things over to Dr. Lee.
Well, thank you so much for having me. I'm the fifth talk of MDRO series. You can find the other talks on ARC-IPC's website, and I highly recommend reviewing them because each of them are building on the idea of understanding how to prevent MDROs in your facility or in your healthcare system. I have no relevant financial disclosures. Here's our outline for today. I'm going to discuss MDRO prevalence in healthcare settings, the role of MDRO colonization and risk factors associated with that colonization, and then review the literature on active surveillance screening in select multidrug-resistant organisms. So a bit of a rapid review here, and this is really building on some of the other talks that you've heard in this series. So what exactly is an MDRO, or multidrug-resistant organism? This is a microorganism. This is predominantly are bacteria that are resistant to one or more classes of antimicrobial agents. You can think of it in three big buckets right now that we are learning about MDROs. So gram-positive organisms are going to be MRSA, or methicillin-resistant Staphylococcus aureus, as well as vancomycin-resistant enterococci. Your gram-negative organisms can be anything like Klebsiella or Pseudomonas or Acinetobacter, or you can think of it in bigger buckets like extended spectrum beta-lactamase producing bacteria or carbapenem-resistant bacteria. And then lastly, in the past few years, we've seen fungi emerge, particularly Candida auris, as a multi-drug-resistant organism. Now, clinically, for the most part, multi-drug-resistant organisms have very similar clinical manifestations to infections that are caused by susceptible pathogens, but we know based on the literature that these can increase length of stay, increase costs, and increase mortality. And there have been a few studies that I want to highlight those different aspects. So in the first, which is shown here in this above the increased mortality, there was a cohort of 477 patients. They were admitted to a large hospital, and they looked just at patients with Enterobacter, which is a type of gram-negative bacteria. And this showed they looked at those that had resistance to cephalosporins like ceftriaxone compared to not, and those patients had a 5-fold increase in mortality. In a neonatal intensive care unit outbreak with ESBL, or extended spectrum beta-lactamase Klebsiella pneumoniae, infected and colonized babies had a longer length of stay than those without an infection. And the cost of just trying to mitigate that outbreak equaled about $350,000, and that's in 2003 dollars. And then lastly, we know that vancomycin resistance has been reported as an independent predictor of death in patients that have Enterococcus bacteremia. So we really want to do everything that we can to try to prevent those infections occurring in susceptible patients. So from a prevalence standpoint, there has been work done by the CDC to try to understand how many counts we have, or what is the total prevalence of multi-drug-resistant organisms. And so this was looking at national case counts for both hospital onset and community onset infections caused by a variety of different multi-drug-resistant organisms. This is from 890 hospitals from 2012 to 2017. And overall, this is about 40 million hospitalizations, so about 20% of the hospitalizations annually that is represented in this data. And so what they found was over about 600,000 infections in hospitalized patients that were due to multi-drug-resistant organisms. About 80% or so were based on the community onset, and then 17% were hospital onset. Now, if you look at the different trends, as you will see here, overall, year over year, we've seen significant improvements in certain pathogens. So methicillin-resistant Staphylococcus aureus and carbapenem-resistant Staph aureus have overall seen a 20% decrease and nearly a 40% decrease. And a lot of the work that has helped with that has really been based on the hospital-acquired infections. Some of the processes and bundles that we have put into place to try to prevent patients from getting these infections. Similarly, you can see in slide E and F that a significant reduction in carbapenem-resistant Acinetobacter and multi-drug-resistant Pseudomonas, both of which are very commonly seen in the hospital onset area. Now, in some of these other areas, though, our extended spectrum producing Enterobacterales and carbapenem resistance have either increased or really there's been no trend over time. So based on those numbers, the CDC created this 2019 antimicrobial resistance threat report. And based on that, they estimated that we have about 2.8 million antibiotic resistant infections each year and 35,000 deaths from that antibiotic resistance. And then if you include C. difficile, then that's an additional 200,000 cases and 12,000 deaths. Overall, there have been huge increases of erythromycin resistant group A strep, drug resistant Neisseria gonorrhea, and then our ESBL producing bacteria. So through this report, they were able to identify some urgent threats. Carbapenem resistance is one of them, Candida auris, which we will talk about, and C. difficile. And then within our healthcare system, there are challenges that are going to be very different than the challenges that are seen in the community. And so I think that this document was really hoping to help different areas try to tackle antimicrobial resistance. Well, unfortunately, when COVID-19 happened, we saw a pretty significant increased rates of hospital-acquired infections and multi-drug-resistant organisms. If you look just compared to 2020 in the Q3 versus 2019 Q3, most states had a 50% increase in some of their hospital-acquired infection metrics, with the highest being in ventilator-associated pneumonia and our hospital onset MRSA. And so through this, the CDC put out an interim report that took that information from that 2019 threat report, and you can see in the red column the change overall. And so highlighting here, carbapenem resistant Acinetobacter had overall a 35% increase in the total numbers. And within the hospital, we saw significant increases, nearly 80% there. Similarly, Candida auris has had a 60% increase. What was improving with carbapenem resistant Enterobacterales flipped the other way, and we saw increased numbers. And similarly, this antifungal resistant Candida overall increased as well. With our ESBL producing Enterobacterales, the overall we saw a community increase in those numbers and a hospital increase. And then, and you can see our vancomycin resistant Enterococcus, which was stable before, has increased over time. Lastly, this threat report is quite long, but the other two that I wanted to highlight here was Pseudomonas and Staph aureus. And so that hospital onset Staph aureus really did increase during COVID-19. I want to highlight, so there, the CDC has different ways to looking at this data. And this is looking at rates of resistance in hospital-acquired infections. And I chose Alabama because that's where I live. But you can see that compared to the United States, total rate numbers, Alabama has a higher rate of MRSA, has a higher rate of carbapenem-resistant Enterobacterales, and multi-drug-resistant Pseudomonas. So I think there's a lot of opportunity here to improving those numbers over time. So what do we know about multi-drug resistant infections? Well, to mitigate that spread of infection, we have to understand what our total numbers are. We need systems, surveillance systems to track the incidence, the prevalence, and the spread of antimicrobial resistance. And we also know that colonization increases the risk of infection, and it's an important source of transmission to multi-drug resistant organisms to other people. I think Kate Draper had a very similar picture in her MDRO talk. If we're only looking at the infections that patients have, we're really just getting the tip of the iceberg here. We really want to understand more about that colonization in patients, and that's what's known as active surveillance. Our current systems right now, we are missing some of that active surveillance, those unidentified clinical infections, and maybe the colonization piece, which is the really bigger part of our iceberg. A good example of this is this recent study that came out in 2019. This is through the SHIELD initiative. So it's Orange County, which is in California. But they looked at 21 different nursing facilities, some without ventilator beds, some with ventilator beds. And then they took a random sample of 50 adults from these. who were screened for MRSA in their nose, vancomycin-resistant enterococcus rectal swabs, ESBL producing organisms, carbapenem-resistant Enterobacterales, and they used the nares, the skin, and the perirectal swabs. And it's interesting if you look at this, because you can see here that they looked at the chart history for any sort of multi-drug resistant organism. So those are those patients that had a known infection with that. And the numbers are about right around 20%, depending on where you're looking. But after they looked at colonization, you can see those numbers increased significantly. And what they found was that the prevalence of the multi-drug resistant organisms was about 65% in nursing homes and 80% in long-term acute care places. And so it's much higher than what was reported in the literature prior to the study of about 20%. So I think if we're not assessing those, we're not learning about who could potentially be colonized, and there may be those transmission events that are occurring in facilities that we may not be capturing. So ultimately, early identification of high-risk patients for multi-drug resistant infection is crucial to curb the spread of MDROs and to minimize patient outcomes. So with that being said, I want to talk a little bit further about understanding the role of colonization in the spread of multi-drug resistant organisms in healthcare systems. You can think about it in two different ways. So the first is this one way where Model 1 is where those multi-drug resistant organisms are shed from a colonized patient through fecal contamination to surfaces and shared instruments in patient rooms. The other is thinking about how MDRO infections could be coming from the microbial communities that are persistently colonizing hospital-built environments, particularly plumbing sources. So the patient is in the room, and then they get exposed to that MDRO colonized in the room, and then they can become colonized themselves, and then that can lead to infections. Now, these two hypotheses are really complex, and so to understand them, researchers have to determine what are the hospital surfaces that are acting as reservoirs, what are the spatial and temporal dynamics of that reservoir colonization, and are resistant strands colonizing the hospital-built environment also detected from human clinical infections? So let's talk about this first model. So the colonized patient colonizes the environment. So in 2001, NIH actually experienced an outbreak of carbapenem-resistant Klebsiella pneumoniae that affected 18 patients, unfortunately 11 of whom died. So this was a novel pathogen at the time. And so when they looked at this, they found one patient who was transferred from another facility into their ICU. They were already known to be colonized with that drug-resistant infection. They were placed on the appropriate isolation and then did not develop any further positive clinical surveillance cultures. But then they identified a second patient about 6 weeks later in the same ICU, found to have that same bacteria from a tracheal aspirate. When they looked into this, they didn't identify any overlap in the intensive care unit stay with patient 1. They did something called pulsed field gel electrophoresis that found that these isolates were very similar, but they couldn't really confirm the connection at that time. And then in the following weeks, they had one new case of either colonization or active infection detected each week for a total of 17 cases. And so through this outbreak investigation, they did a lot of work, including whole genome sequencing. And this process really led to this map that was developed. And you can see how complex it is. So in A, you can see the start of the investigation, where that first patient that came in June of 2011, they really were there in the hospital. You can see that in those blue bars in B, the blue is ICU, the red is a different ward. They were really not in the intensive care unit for very long. And then through that process had multiple different cases. And so they actually were able to map this out, and it was patient 1 who overlapped with patient 3. And so through that, this very, very difficult kind of graph was created to show how complex we can see this transmission. And some of this happened because they were not testing for colonization. There was another issue with what found a contaminated ventilator at the same time. There were 3 independent transmission events from one colonized patient. And so it's very, very complex. And so in infection prevention and infectious diseases, we want to break these chains of events, of transmission events, as much as we possibly can, and work through those tools to figure out what we have, what can we do with our patient population, and what makes the most sense clinically. What we also know is that these patients move around our healthcare system very frequently. So I'm speaking from the hospital perspective, but you know that a patient, this is looking at Clostridium difficile or Clostridioides difficile. These patients come in through the emergency department. Maybe they go to different hospital wards, but oh, we're going to send them to the CT scanner. They need to go to ultrasound. Maybe they need to go to OR to have a procedure done. They're going to dialysis. It's very complex how frequently they move in and around our hospital environment. And so making sure that we have those infection prevention policies in place to protect those other patients is key. Now, when we have a patient that may already be colonized with a multi-drug-resistant organism, what we know happens is that they touch their own hospital environment. So this is a picture here of actually one of our units. And when we look into this, I call it having infection prevention eyes. So thinking about what could potentially be colonized with different bacteria or different multi-drug-resistant organisms. And these are all the things that potentially could be touched in one patient's stay. So the chair, the bedside table, anything on the bed railings, the door itself, that computer that's in place right there, they all could potentially be touched either by the patient or by the healthcare worker. So we have to do a lot to prevent that transmission from the environment to the patient or the patient to the environment. This was a study that on the right-hand side that looked at over 400 patients looking at microbial surveillance of the nose, the hands, and then 6 high-touch environmental surfaces on day 3 of admission, day 7, and then weekly thereafter. What they found, of course, is that 10% of patients were just colonized with a drug-resistant organism at baseline. Interestingly, about 30% of the rooms in this study were colonized at baseline as well. And they looked at that new acquisition, so day 3, 7, or weekly thereafter, of whether or not these patients developed a multi-drug-resistant organism on their hand. And they found that 6% of newly acquired multi-drug resistance occurred on the hands during their stay. So that was a rate of about 24.6 per 1,000 patient days. What does that mean clinically? Well, maybe the patient washes their hands, but if they touch their face or they touch something else, that could potentially lead to a persistent colonization that then could lead to infection. All right, so that was model 1, where we were talking about how the patient can colonize the environment. The other model is the hospital environment can be colonized with multi-drug resistant organisms, and that can lead to infection. And over the last 20 years, there have been multiple reports of carbapenem-resistant organisms in the hospital water environment. These reservoirs typically are drains, the sink trap, faucets. They're very frequently colonized. This can lead to infections in critically ill and immunocompromised individuals. And if you look at it, about 70% or so report control of the outbreak, but only about a third were able to eliminate that organism from the water environment. So we talk about this frequently in our infection prevention meetings at UAB about how can we prevent something that we know is colonized and very difficult to get rid of from splashing up and causing an infection in a patient. All of the studies that were assessed during this found cross transmission between patients and the environment based on epidemiologic links. And then they also did molecular testing. And there were multiple infection control breaches, including poor sink design, sinks contaminated with waste disposal. There was storage of clean patient materials around sinks, reuse of non-sterile drapes, et cetera. So all this to say that this multi-drug resistant colonization occurred on the patient because of the hospital built environment. In a similar way, other researchers have tried to see, well, how long does it take for a new unit to become colonized with these multi-drug resistant organisms? So this was, they took sampling of multiple surfaces in an established and newly built intensive care unit in addition to taking patient samples, and then they performed what's called whole genome sequencing to see if those organisms are very similar. And what they found was that antibiotic-resistant organism burden is highest in the sink drains, like we said already, compared to other surfaces, including Pseudomonas aeruginosa was found in multiple sink drains and multiple patient isolates. And so it was rare to find reservoirs on hospital surfaces, but in that sink, it did remain in there. So we have a lot of work that we're fighting against, a lot of things that are against us in the hospital-built environment and long-term care facilities to trying to prevent that spread of infection to a potentially susceptible patient. So what are some of the strategies that we have to prevent acquisition of multi-drug-resistant organisms? So the CDC luckily has developed these categories or tiers of resistance to help you kind of think through how to tackle these different infections. So tier 1 is when you have an organism that's rarely been described in the United States, and because of that, extensive evaluation is required to determine the risk of transmission and the extent of spread. So tier 1, a good example of this would be Candida auris. I think we are still working hard to try to prevent the spread of that infection in our hospital systems. Tier 2 is when you have a multi-drug-resistant organism that is primarily associated with a healthcare setting, but they're not commonly identified in your region. So for instance, if you don't normally have a metallo-beta-lactamase resistant infection, which we don't normally have those here in Alabama, if we see one in our hospital, we will treat that as a tier 2 organism. Tier 3 is when you have multi-drug-resistant organisms targeted by your facility for epidemiologic importance. So maybe those are going to be your carbapenem producing organisms. And then number 4 is when you have a multi-drug-resistant organism that's endemic in your region, but it's been targeted by public health for their clinical significance. A good example of this would be MRSA. We know that there are good reasons that we target MRSA to try to prevent the spread of that infection. A way that you can think about this, tiers 1 through 3 are typically the way we think about for containment. And then tier 4 is more about prevention. And you can see about, how many cases you would expect to see with each of those. Now, within the CDC does have a great toolkit response for containing multi-drug-resistant organisms. And they include, based on the tier, some of the elements that you should focus on. Today, I want to focus on the data supporting active surveillance and screening of patients. And why would we use that to help as one of our tools to prevent the spread of multi-drug-resistant organisms? So I think the data supporting active surveillance, some of the best data is in our gram-positive organisms because we have seen MRSA for quite some time. And so a lot of the work about MRSA screening initially started in the VA. So there was a VA initiative to prevent MRSA infections, and they created this bundled elements in 2007. And that included universal nasal surveillance for MRSA, contact precautions for patients colonized and infected with MRSA, and then hand hygiene. They had a hand hygiene coordinator, MDRO coordinator that came with this. And what they found was that the prevalence of MRSA was nearly 13% if you included both the clinical cultures and then the surveillance screening. You can see on this picture on the left, the clinical cultures really were less than 2%. And the rest were these surveillance screening positive cultures for MRSA. What they also found with all of this work here is that the rates of healthcare-associated MRSA infections in the intensive care unit declined by 62% and by 45% in acute care units over time. So just in this 3-year period, they were able to show improvements overall in MRSA. Interestingly, if you look at those MRSA rates over time, because the VA is kind of a microcosm of patients, they can look at both of their hospital-acquired infections and their community onset infections. These patients are kind of remaining in the system of the VA, and what they found through this multifaceted approach, including screening for MRSA, this reduced the risk of acquisition for both hospital onset MRSA and community onset MRSA. So the acquisition of MRSA colonization decreased by nearly 78%, which is about 17% per year, which is pretty amazing work to thinking about tackling one particular pathogen and improving rates of infection over time. So why perform active surveillance for MRSA? Well, we talked a little bit about this. You know, we want to prevent, maybe you're instituting control measures to prevent transmission to other patients and healthcare workers. You may want to use MRSA surveillance to decrease the risk of infection to the carriers themselves. So you can think about that in terms of decolonization practices for surgical site infections. And then also you may use this as part of stewardship to reduce vancomycin use. There's been really great studies that have shown that a negative nasal PCR has a high negative predictive value, meaning if I don't isolate MRSA from my nose and a patient is presenting with pneumonia, then the likelihood that they have MRSA causing their pneumonia is less than 5%. So it's really great test where you can say, hey, we don't need to be starting that vancomycin anymore. We can focus just on standard pathogens that cause pneumonia. The SHEA, Society for Healthcare Epidemiologists of America, actually recently updated their compendium guidelines for MRSA. And in terms of active surveillance testing, they have some moderate quality evidence that say, number one, implementing that AST program for select patient populations as part of a multifaceted strategy to control and prevent MRSA. Number two, you can do the active surveillance in conjunction with decolonization for targeted populations such as surgical populations to prevent SSIs. They did say that active surveillance with contact precautions is inferior to universal decolonization for reduction of MRSA clinical isolates in adult ICUs. There's a large study that found rather than me testing and saying, okay, you need to have your special CHG soap and mupirocin, just saying anybody in the ICU is at risk. Let's give everybody that nasal decolonization and CHG specialized soap to try to prevent that acquisition of MRSA. That has been shown to be more beneficial than just targeting alone. And then lastly, our hospital-wide surveillance for MRSA can be used in conjunction with contact precautions to reduce the incidence of MRSA. That evidence was moderate. And then lastly, active surveillance can be formed in the setting of an outbreak. So what about vancomycin-resistant enterococci? So there's not as much in the literature anymore about this. This data is actually from 2000. And this is just showing a case study of over a 13-month period of a burn unit that found an outbreak of VRE. So this picture on the left shows the nurse's station was in the middle. There was a waiting room very close to that. The hydrotherapy room is over there. And then you can see the multiple rooms are just very close to one another. What they found was that they had a case of VRE bacteremia followed by multiple cases of colonization. And then ultimately they found a contaminated EKG lead and improper bronchoscope cleaning. Now this data is from 2000. So we have a lot more data that helps us understand how to do bronchoscope cleaning and EKG lead cleaning. But it's just evidence that we can see these bacteria that can be transmitted from one to another. And the way that this was eradicated was using enhanced cleaning, active surveillance, and contact precautions. So moving on, discussing the data supporting active surveillance testing in gram-negative organisms. So you can, as we know, for multi-drug-resistant gram-negative organisms, we unfortunately don't have decolonization for people with that. With Staph aureus, we have pretty good data to show that if we identify somebody, we can use that to decolonize them, particularly before they have surgery. But what we have for these gram-negative organisms, we have clinical monitoring of signs and symptoms of infection. We can perform active surveillance cultures, and then we have laboratory tests to identify resistance to carbapenems. But really, the screening and implementation of contact precautions actually remains as an area of controversy because there are different recommendations regarding which patient groups to screen, when to screen, and which laboratory methods to use. I want to highlight a couple of studies that have tried to look at specifically active surveillance for carbapenem-resistant Enterobacterales. So this is a retrospective time series of patients admitted to ICUs from 2015 through 2017. In the first period, they had no screening protocol. But in period 2, their screening protocol included anybody over the age of 65, if you were in the hospital for more than 7 days, if you were given antibiotics like carbapenems or certain cephalosporins for more than 3 days, if you were immunocompromised in some sort of way prior to your admission to the intensive care unit. So if you met any of those criteria, then you underwent screening. And so then they would do that rectal screening at the time of admission on day 3, day 7, and then every other week. All the positive patients were placed on contact precautions, and then they were cohorted with other carriers, and the healthcare workers received intensified education, cleaning, and hand washing program. So the study included over 5,000 patients, and just with their criteria, about 70% of those patients underwent screening. And so during period 1, you can see that CRE increased by 13% every month. And then, of course, during period 2, it decreased significantly. So while they initially found more cases of carbapenem-resistant infections, but because they put them on contact isolation and did enhanced education and more cohorting of patients that had similar infections, they were able to reduce that over time. In a similar group, this is actually out of the United Kingdom. They saw local rise in their carbapenem-resistant infections. And so they decided to do screening similarly in a high-risk intensive care units combined with weekly screening. Then they did risk factor-based screening for all other admissions. And then if any ward had any patient with CRE, they would also screen all the patients on there for the duration of their stay and then 4 weeks after. And what you can see here is that those light gray bars are your clinical blood culture. The dark ones are the other, and then you can see the screening as well. So it's a little bit difficult to see, but most of the gray ones are the screening samples. And what they found was that 87% of their CRE was from those screening samples. And then mainly the number of CRE infections decreased monthly, but you can see that in the early part of the January of 2015, they actually did have an outbreak of these infections. So they identified an outbreak, but then they also were able to control better with active screening and then placing these patients on contact precautions. So there was a recent study just trying to look at, do active screening strategies actually prevent hospital-acquired infections related to drug-resistant gram-negative infections? And so they looked at all-cause mortality, which showed really no difference, as screening may result in little to no difference at all for all-cause mortality. In terms of length of stay, very similarly, they didn't really see much difference. If you put patients on that isolation, it's not going to lead to them being on a longer length of stay. They did see that carbapenem-resistant gram-negative infections decreased significantly, like I showed before. They also looked at multimodal interventions and found significant reductions in infection rates after implementing surveillance cultures along with a whole bunch of other infection prevention policies. And then lastly, carbapenem-resistant colonization can be reduced as part of multimodal interventions, so that screening surveillance is helpful because it may reduce colonization going forward. The last area that we'll talk about is Candida auris. So just so you know, Candida auris is a drug-resistant infection. It can cause serious infections, including bloodstream infections, surgical site infections. And because of how resistant it is, more than 1 in 3 patients with invasive Candida can die. They're commonly resistant to many of the antifungals that we use to treat Candida infections. It's becoming more common since 2009. It has spread very quickly. Sometimes it can be difficult to identify. You have to work closely with your lab to be able to identify it appropriately. And I like to think of Candida auris as a fungus that acts like another multi-drug-resistant organism. It can spread easily in hospitals, nursing homes, and cause outbreaks. What we can see here is that the number of Candida auris clinical cases, this is through December 31st, 2022, and it is starting to spread kind of more out west since this data has been shown. And the number of clinical cases have really just skyrocketed, and it's not surprising that this kind of correlates with the timing of COVID-19. When we look at what particularly is it about SARS-CoV-2, which is COVID-19, or Candida auris, just that the pandemic led to a large number of critically ill patients in intensive care units. And so, unfortunately, there were multiple healthcare systems that dealt with outbreaks related to Candida auris. You can see that that specialty care unit in Florida had 52% of their patients colonized with Candida auris. 12 patients in Mexico, in India, you name it, there have been multiple case studies of patients colonized with Candida auris. And if you look at this tornado diagram, what it shows is that the risk factors are in green, and then the responding the containment measures in yellow. And so inadequate PPE really led to a lot of Candida auris being spread. And so doing PPE and hand hygiene audits really did help mitigate a lot of these PPE shortages, high antibiotic use, et cetera. All of those things really helped. But if you have reduction in patient screening, which is kind of midway down on that tornado diagram, enhanced screening is also something that people have used to try to identify patients early on. Some of the early work before 2019 looking at Candida auris occurred in New York State, because that was one of the few states initially that had cases. And this study is really interesting because I think it shows how connected we are in terms of healthcare facilities. This was 51 cases. Most died within 90 days, about 45%. And 98% were resistant to fluconazole. They performed screening cultures at multiple different institutions. About 11% of these patients were positive. And then they also did environmental cultures around here and found multiple facilities colonized with Candida auris as well. What this figure shows are the epidemiologic links between healthcare facilities. And so you can see the ones that have the triangles are people's houses, where you can have someone who's colonized or someone who actually has a screening sample that's positive, going to a healthcare facility, which then may go to a long-term care facility. So we are more connected than we realize. And I think this study just shows how difficult it can be to mitigate the spread of a novel multi-drug-resistant organism. Additionally, what this study shows is during 2016 to 2018, the New York Department of Health conducted this point prevalence survey to look at Candida auris colonization among patients in multiple different long-term care facilities. And then they took those and did like a case control investigation to look at someone who was colonized with Candida auris versus someone who wasn't, to figure out, what could be going on that could leave them at risk to being colonized. And so they found that invasive medical devices, recent antimicrobial use, if you've had a history of another drug-resistant organism, or recent hospitalization, those have all been associated with Candida auris. There are not many studies that have looked yet about if active surveillance cultures can help prevent transmission of Candida auris, though. One of the interesting things that came out of this study is if you look at this facility, you can see that the red are the positive cases and then the blue are the negative cases. So you would expect that someone that was positive for Candida auris, that their roommate would also be positive fairly quickly for Candida auris. But that actually did not happen among these residents. And it's unclear why maybe some of the colonization doesn't transmit nearly as well to someone in that room or not. So I think we are trying to learn more about Candida auris colonization. How does it happen, and who's at risk, and what can we do as healthcare facilities to prevent that colonization? So I just covered a lot of different studies looking at active surveillance testing as one strategy to help reduce multi-drug-resistant organisms. How can you take that information and make it usable for your facility? I think there are roadblocks for implementing active surveillance testing. There are multiple different methods for surveillance for healthcare facilities. You can do that universal active surveillance culturing, meaning screening everybody that's coming into your facility. You can do targeted screening, where you screen specific populations at risk for multidrug-resistant organism, which we described in that case for carbapenem-resistant Enterobacterales. Or maybe you'll do a point prevalence survey where you're screening a whole unit in response to a potential exposure. It's also unclear, like, the timing and the intervals for active surveillances. Like, different people have done different things in the literature. There are different laboratory methods, including the rapid non-culture-based tests like PCR, or you could do culture-based tests. But there are high costs noted with this. So there was a study that looked at 2 neonatal intensive care units, and they discontinued their active surveillance program for MRSA. And what they found, that the total hospital cost saved was about $500,000 to $600,000 annually, or about $450 per patient. And that's including cost and isolation that's associated with that. So while the test may not cost a lot of money, you do have to think about the downstream effects of, can we afford doing the contact isolation? Is it appropriate to do so for these particular pathogens? The other thing that I will say is that we really need more research, because a lot of the current literature studies in infection prevention look at a lot of bundled elements together. So these are multi-component interventions. I mentioned here that active surveillance, we did active surveillance, and then that led to contact isolation. So was it the active surveillance that helped, or the contact isolation, or is the fact that we identified those patients early on and then used appropriate isolation practices to then reduce those numbers? I think we really need to think more about that going forward. If you go to the CDC's website, when they're talking about all of the data that they use to synthesize how to prevent multidrug-resistant organisms, you can see that they summarize for these different pathogens all the different studies and what they did. And so many of these things, so surveillance cultures of patients occurred very frequently. But maybe putting patients in private rooms, some patients did that, versus education, versus using antiseptics for hand washing, et cetera. So I think we really need better ways to tease out how doing one thing may help reduce these, or is it doing all of them together? So the way that I think about this when you're considering starting active surveillance testing is, number one, you need to really make MDRO, prevention and control, an organizational priority. We can be screaming into the void over here saying that we have a drug-resistant problem, but if you don't perform a risk assessment and understand the community and facility rates and present that in a way that your leaders in your healthcare facilities understand, we may not get the fiscal and human resources to prevent and control that MDRO transmission. After that, you want to implement systems to communicate that information about reportable MDROs within your facility, but then also with your state and local health departments. I've spoken to people in the state health department when we have cases. I've spoken to CDC. Everyone is all very helpful in trying to prevent these infections, and it should not be considered a barrier if you do have to notify your health departments. You want to implement multidisciplinary process to monitor and improve hand hygiene, and also healthcare worker adherence to recommended practices for standard and contact precautions. I've mentioned a lot of things about hospitals, but long-term care facilities have different precautions for standard precautions. They have enhanced barrier precautions, but any system that can help you monitor that is key. And then you want to implement a system to designate patients known to be colonized or infected with multidrug-resistant organisms. Now, in terms of performing AST, we have healthcare facility labs that you may work with, but if you don't have a lab that can do that, I would reach out to your public health department, because they may have connections to the AR lab network, or antimicrobial resistance lab network. What this lab network does is that it provides nationwide lab capacity to rapidly detect antibiotic resistance in humans related to healthcare, food, community, and the environment. And so they have core testing performed for these 7 regional labs, and that includes molecular testing for detecting carbapenem-producing organisms, Candida auris colonization. They can do antifungal susceptibility, whole genome sequencing, if needed, et cetera. So if you are a facility that cannot afford it, reach out to your health department and they can help be the liaison to connecting to these AR lab networks. I do want to highlight what UAB does and kind of how we think about this. So MRSA, I would say, is a tier 4 level because it is endemic. So we do targeted unit NARI screening. So we screen all of our patients in the intensive care unit. And mainly, we're not doing this to target and decolonize because we decolonize everybody in the intensive care unit. Instead, we're using this test to identify high-risk patients and then using that negative predictive value for stewardship purposes. So if you have a patient coming in the intensive care unit and they have sepsis from pneumonia, and you have a negative NARI's test, you can feel pretty confident to remove that vancomycin because you may not need that for community-acquired pneumonia. For our multi-drug-resistant gram-negatives, I would say that depending on which gram-negative, we consider them tier 2 or tier 3. And so we're doing targeted patient admission screening. So these are rectal swabs. And so we screen and implement contact precautions, and we also have enhanced screening. That's actually shown improvement in rates of our MDROs in select patient populations. And right now, I would say Candida auris, because it was fairly new in Alabama, we are treating this like a tier 1 organism. And so we are doing targeted admission screening, and we are doing point prevalence surveys if we identify a case that was not known to be positive before. Right now, I would say we're assessing that process thoroughly, understanding how we can drive change and maybe looking at culture versus PCR method for screening. Now, for Candida auris, just as a reminder, it's a screening in the axilla and the groin. MRSA is the nose, and the gram-negatives are going to be perirectal screening. So all of that comes with education for our healthcare workers as to how you get those swabs, what's the best practice, et cetera. Now, I do want to say that there is hope on the horizon. I think this is a great study that came out recently in JAMA, reducing hospitalizations and multi-drug-resistant organisms via regional decolonization. And so the question here is, is implementation of this regional hospital and nursing home decolonization collaborative, so working with hospitals and nursing homes in a particular area, can that reduce MDROs, infection-related hospitalizations, costs, and death? The answer is yes. So this was a quality improvement study, 35 healthcare facilities, and they did chlorhexidine bathing and nasal decolonization, and they found lower MDRO prevalence and incident clinical cultures, infection-related hospitalizations, costs, and deaths were also decreased. So while there may be an upfront cost for some of these infection prevention priorities, the overall cost of reducing hospitalization and death is significant. So with that being said, I will open it up to questions.
Thank you so much, Dr. Lee. I want to remind everyone, if you do have questions, drop them in the Q&A box, and we'll get to as many as we can with the time remaining. Some of these questions came in earlier, Dr. Lee, but I want to make sure, and you have slightly addressed them, but I want to make sure that I ask them of you. First one was, I'm a new IP in a nursing home. What is the best way to identify residents that may be colonized with an MDRO?
That is a great question. And I would say that the first thing to do for your facility is a risk assessment. And I forgot to mention in one of the slides, which hopefully you will get in a PDF form, there's a link that helps you do a risk assessment that the CDC has created. And that kind of helps you understand, how do you get culture data for your patients? How do you, what types of tests can your lab do? And so the big thing is understanding what the lab capacity is for your patient population. If you are in a nursing home, I would also say reach out to your local health department. They probably have that connection to that AR lab network that can help with screening colonization for your patients.
Sounds good. Another question that came in earlier, and this was when you were presenting on the strategies to control MDROs. Someone asked, does the CDC have numbers or percentages per tier that would be tagged as an outbreak?
That is a great question. And I think that they, in that MDRO containment booklet that they have, they talk about, what's considered a cluster versus an outbreak. In tier 1, a lot of times if you see one case, you almost treat it like an outbreak, because what you want to do is to act quickly in order to contain that spread of infection. So I think, yes, I just can't remember the numbers on the top of my head.
Sounds good. This one is about long-term care facilities. So long-term care facilities that are being asked about pre-screening for MDROs are worried about identifying large outbreaks and any repercussions from identifying those outbreaks regarding regulatory compliance. What is the best way to get long-term care facilities on board with this recommendation? Any suggestions that you have are greatly appreciated.
Yeah, that is a great question. And I think everybody struggles with, what is the implication of, identifying these patients and then potentially being, marked as like, oh, this facility is having an outbreak, et cetera. I will say every healthcare facility deals with, unfortunately, clusters of cases. It just happens. And so if you can write out very clearly, like, here's why we are doing this, and hopefully some of these studies will help you say, if we identify these early on, if we do a multifaceted approach to education, to understanding the screening and how to prevent those infections, we're going to save money in the long run. I think that would be the way to talk to your healthcare administrators to say, this is important and we need you to really focus in on this so that we can work within our state, within our institution. I will say that I'm in Alabama, and our state health department has been amazing to work with, because they really try to take a non-judgmental viewpoint of, okay, you're having a cluster of cases, let's talk through this together to figure out how we can control this quickly. So hopefully your health departments can also be a good resource for you.
This is a reoccurring question because someone just asked very similar, other than education, other methods to overcome facilities who push back on surveillance screening. So I think you gave some great examples and some ideas. The last question that I see here, someone is asking, can you describe what constitutes enhanced cleaning for MDROs at UAB?
Yeah, that's a great question. So one of the ways that, we identify these patients, we do have electronic healthcare records. And so if a patient is colonized or has an infection with that drug-resistant organism, it will either send it to just regular contact precautions, or if it's one of these pan-resistant organisms or Candida auris, it will choose something called enhanced contact precautions. And with that enhanced contact precaution, we double clean the rooms, which is really helpful for our EBS to know, hey, I see this red sign, I need to clean the room twice. So that's one method of enhanced cleaning. The other method that we have is we have vaporized hydrogen peroxide, known as HaloSeal. BioQuell is another company that makes that. Those methods, another enhanced cleaning method would be UV light. Those have all been shown to help reduce those risks of or help improve cleaning, but you have to have a good cleaning process up front. If you UV something that's still dirty, or if you do hydrogen peroxide that is still dirty, it doesn't really clean the room. So really our biggest focus is doing that double clean. And then we're augmenting with HaloSeal when we can. I think as every healthcare system has been dealing with this, sometimes we have many patients and we may not be able to HaloSeal every room every time. So we actually have a system in place for our high-risk units to clean those rooms on a quarterly basis with that machine.
Sounds good. We're at the top of the hour, so I want to wrap things up. Thank you again, Dr. Lee, for this webinar, for being part of our MDRO webinar series. And for everyone else who is joining, we hope to see you again to wrap up the series on July 10th at 1 p.m. Central Standard Time. Everyone have a great rest of the day. Thank you.